Good morning, everyone. Welcome to Coplow Rounds. We've got some great cases for you today, and we will get started. All right, so here's our first case. We have a very interesting pair of cases for you up front. If it will go, there we go, it went. We have a very interesting pair of cases for you today up front. So starting with this owl. So this is a 9-month-old intact male great horned owl. And they note that this owl was born with a very small eye. So we've got microphthalmia and presumed multiple ocular anomalies. The eyelid opening was very small, as is the globe and cornea. And that's the main history that we have, and the duration of problem since birth. This is very interesting. You'll note that the ruler down here, each of these divisions is a millimeter. So this is a very small eye, even for a young owl, quite small indeed. And a little bit on differentiating microphthalmia and thesis bulbi. Both things can cause a small eye.
What is thesis bulbi for you?
Thesis bulbi. Yes. So the question is, what is thesis bulbi for those listening who may not know? And so this is basically like chronic scarring of the eye. Over time, the eye can develop intraocular fibrosis, and that fibrosis can cause contraction. You get marked wrinkling of the collagenous tunic. So cornea and sclera tend to be quite wrinkled, and the eye will be kind of small and shrunken. So basically like a chronically scarred eye. And basically both conditions, microphthalmia and thesis, can result in a small eye. And basically some of the things I've said about thesis is what I would look for to differentiate the two conditions if I'm doing a gross exam. So an eye full of fibrosis with marked wrinkling of the collagenous tunic would more likely be thesis. An eye that is reasonably well-formed and unwrinkled, per se, sort of, but small, would probably more likely be microphthalmia. In this case, I do favor microphthalmia, but we'll continue to look at this case to explain why. There isn't really all that much fibrosis, although there is some white tissue in here, and we'll see what all this stuff lining the inside is. There is a very small cornea. We are relatively central in the cornea, and basically all it is this tissue from here to here, which is also pretty opaque and thick. There isn't really much evidence of an anterior chamber on gross exam. It's pretty much all just tissue filling this area here where there should be an anterior chamber. At least grossly, there really isn't much of a lens apparent. Can't really make one out. And then just some other features of a bird eye. So we have these great big tan structures here, kind of up in limbal sclera, and these are the scleral ossicles. Most likely they look enormous and club-shaped in this case, just because the eye sort of didn't really develop at the same time as itself, the different components. Scleral ossicles, we can see them. And we can also make out the scleral cartilage on gross exam too, this sort of translucent tissue all the way around in the rest of the sclera. The other thing that is really important to note grossly, so the optic nerve is roughly about here. And that said, here is where we should expect to see a sort of optic nerve head. And there's a structure that's conspicuously absent at that site. So birds should have a pecten, which grossly would look like a brown kind of fan-shaped structure extending from the optic nerve head into the vitreous. It's very important vascular supply for the inside of the eye. And there really isn't one apparent grossly. Checked both halves, and this is the half that had the optic nerve and should have pecten too, and it doesn't appear to be there. There is this interesting little nubbin of tannish tissue here, which is not pecten, I promise you. We'll take a look at that later. So a detailed gross exam, but we will now switch to histo. And we'll make it full screen. And we'll pick deeper 3. This is one of those cases where the whole globe fits on as a subgross, which is handy.
Just like the picture.
It looks just like the picture. Isn't it cute?
It's like a baby bird waiting for
we see the same sorts of things as we saw on gross. A very small cornea. It's very brightly eosinophilic and sort of dense looking, and we'll take a look at that closer. We see that nubbin of tissue that we saw grossly down here, and it's not super brown and not pectin, and we'll revisit this in a second. Optic nerve is coming in down here. We did multiple deeper sections hoping to get the optic nerve head just to confirm, no pectin histologically, and didn't quite make it, which is a bummer, but I guess you can't have it all. It's still a really cool eye. So we'll switch from the subgross to the gross, although I think I'm going to want to put it this way, so cornea will be up top. Just for fun. Right. We are at optic nerve again. So let's start up front with the cornea. And it doesn't look like a cornea much at all. Instead, it kind of just looks like sclera. And we can confirm that we're at the level of pupil, roughly speaking. There really isn't a pupil in this case for other reasons, but so this should be cornea, but instead of the usual corneal stromal collagen, which should be these lovely, regularly arranged parallel collagen fibers, these are really dense, thick collagen fibers arranged in sort of intersecting bundles or fascicles, kind of more like scleral collagen than corneal, very abnormal. Essentially, the cornea here is replaced with a more disorganized fibrous tissue. If we look along the deep aspect of that, where we should see Descemet's membrane, we don't see any Descemet's membrane anywhere. I wish I did, but neither of the cases are normal. The question was, do we have a normal so we can compare? And that would have been wise, but none of the cases I have in my flat are normal. Wait, Jamie has a dog. We could do the dog.
It's not a bird, but
At least it's a Descemet's. That is useful, yes. It's a good point. Here's a normal cornea, and pretty much most species will have corneal stromal collagen that looks like this. It has a very regular arrangement. That's part of why it's translucent and lets light through so well. You can see these parallel arranged stromal fibers and a Descemet's membrane at the deep aspect. Most species, not all, surprisingly, but most species have a Descemet's membrane. Cow nose rays don't, apparently. Fun fact. Anyway, yeah, I know, right? Anyway, so thank you for a point. That's a good suggestion. There is a normal for comparison, so you can see just how abnormal that owl is. And thank you, JB. Wait. I've realized lately that I have a habit of putting the label a certain way, which in this case puts the cornea on the, anyway, it doesn't matter. So here is this eye again. So we finished with the cornea, and then here between the cornea and where lens should be, there should be some sort of a chamber, an anterior chamber, and there really isn't one. It's all just sort of full of this disorganized tissue, which blends directly into that cornea. And then the anterior uvea is also quite disorganized. There really isn't a distinct retina here, and elements of ciliary body and iris are just sort of jumbled in together. We see over here, for example, that we have this cuboidal, heavily pigmented epithelium, which is basically iris pigmented epithelium. And we kind of have some muscle, some smooth muscle coming in here. So like this tissue here is sort of iris leaflet-esque, but it's sort of in the wrong spot, and it's just kind of blending into the surroundings pretty weirdly. And then we have this pigmented, more like iris epithelium, and then over here just sort of smoothly blending into more like ciliary body epithelium, which has its two layers. We've got the inner pigmented and the outer non-pigmented, so this looks more like ciliary body, just kind of all like jumbled in together and not really forming a distinct iris and ciliary body separate from one another. Then we also have blending into this tissue and just sort of jumbled up in there, a bit of tissue that is kind of lens. It's a very wrinkled and squished up lens. There is a lens capsule. Here it is, very wrinkled. But that lens capsule is pretty broadly discontinuous. So here's an end, and then another end kind of extends out over in that direction. And there are some lens fibers, most of which are looking pretty degenerate and swollen, Morganian globules and bladder cells. And then through this defect in the lens capsule, we have additional tissue just blending smoothly into the lens. Here we have neuroectoderm, or basically neuroepithelium of the ciliary body. We have that double layer, but it blends pretty smoothly into basically neuroglial tissue, kind of retinal-like tissue. And as we extend out from this area here, we again still have this retinal-like or neuroglial tissue. And that just kind of keeps going. And here and there, we have these basically Morgagni globule or bladder cell looking things, so kind of lens-like things. And this is lenticular metaplasia in the retina at this point, essentially. So Mueller glial cells can basically take on like a lens-like morphology. And that's probably part of what we're seeing as we get further out here, at least from where the kind of lens was sort of trying to develop. And as we walk along the retina, we eventually get to that little nubbin of tissue that I promised we'd look at closer. And it's just this disorganized segment of retina with some areas of lenticular metaplasia. And we do have rosette formation. Here's a rosette, and there's a rosette, more or less. So this is dysplasia, dysplastic retina. We don't really have distinct retinal layers. And it all looks pretty like abnormal retina all throughout. So, long story short, too late, that's this eye. And there are two potential explanations for a case like this. We could have a congenital anomaly, and that is more likely in this case, just because of how everything's sort of all jumbled in together. Or we could have an early life trauma or early life corneal rupture essentially. Basically, in many cases, the chronic sequela of a corneal perforation, usually traumatic, which causes collapse of the anterior chamber and sort of jumbling of tissues for that reason, can be difficult to distinguish from a congenital malformation where the anterior chamber and structures of the anterior segment may not have formed properly. In this case, though, there are a couple of clues that suggest that it's congenital more likely. Including just how all these tissues are sort of jumbled in with one another and not really ever forming normal tissues or like normal distorted tissues, as well as the clinical description of a small palpebral fissure. So there were eyelid anomalies associated with this small eye as well. So if you have additional congenital anomalies in or around the eye, that can kind of clue you in that probably there was some degree of congenital malformation here. So the favored diagnosis in this case is an anterior cleavage syndrome, also known as Peters anomaly, and basically just a congenital malformation of this eye. There we go. A long list of diagnoses.
And to be clear, as Megan pointed out, the differentiation between something congenital and traumatic, it's not always easy / possible.
Mm-hmm.
I could play devil's advocate here and try to explain a lot of the lesions towards a trauma perspective.
You can.
I'll probably succeed.
You could.
But I still agree with you that this looks more likely to be something congenital.
Yeah, this could absolutely have been early life trauma. And indeed, in the official report and here, we still leave this as a differential on our list. Essentially do a descriptive morph and then anterior cleavage syndrome versus an early life trauma are our top differentials, explaining what caused all these changes. Yep.
Great case.
Yeah. Yeah. Now, the owl and the tortoise. It sounds like an Aesop's fable. Our next case is a tortoise.
Better first.
Believe it or not, this actually was from the same submitter, which is really unusual too. But anyway, we'll get to why I'm kind of tickled by that. Yeah, go ahead.
An interesting question from
Go
Carol
ahead.
here. She asked about if the presence of lens capsule rupture would consider it to be acquired, likely acquired on top of congenital.
So congenital anomalies can involve a lens capsule defect. In essence, the lens capsule may never have properly formed. Especially in the posterior lens capsule, you'll see large defects with congenital malformations. So just because the lens capsule is discontinuous does not necessarily help us come down on one or the other possibility. I would say that if a lens capsule is maybe kind of more fragmented and maybe like curling of the ends, I maybe would be more suspicious of a traumatic cause of lens capsule discontinuity. Maybe not really though. So I basically, long story short, it's a good thought, but for me, it ultimately doesn't help us to land one way or the other.
Yeah, I agree. We also have a situation that's kind of common with those processes where the lens is missing, right? And then we debate between like real aphakia has never been formed versus a lens that extruded from a corneal perforation. And it's also difficult to work with. We often think that true lens aphakia would cause a more severe general ocular abnormality, because during embryogenesis, everything kind of forms around the lens in a way. But you can also have like a congenital abnormality, like Peter's anomaly, that causes a corneal disease that then perforates, and then the lens goes out. So we're back at the same spot where we don't know, or we can clearly confirm.
Indeed.
Riley,
Okay.
Harrison, hey, we were talking about Riley earlier.
Yeah.
Today.
All good things.
Could you rule out lens capsule rupture because of the lack of inflammation?
So funnily enough, Jamie actually just wrote a quiet note along those lines. So good point, Jamie and Riley. So I don't think I would necessarily fall one way or another still with that. I think that so I think maybe the theoretical idea is if the body never had like sequestration of the lens proteins, maybe it would be less likely to develop a robust inflammatory response. I don't know. And then if it like ruptured later, but I don't know. I think that the immunogenesis of lens proteins is still kind of unusual and maybe incompletely understood. So I would not be comfortable coming down one way or another because there is or isn't inflammation in the lens.
Yeah, and that's another confusing factor. Sometimes we get very young animals where they clearly have corneal rupture and a traumatic event, and they do not have an inflammatory reaction.
Yeah, and then there's
sorry, go ahead, man.
No, you were in the middle of something.
That one of the reasons why that happened, I think, is that sometimes the trauma happens when the eyelids are still closed, so they haven't opened their eyelids yet. So the closed eyelids kind of protect the intraocular space from inflammation because there's an extra layer there to prevent exposure of the ruptured cornea to the world. But again, speculation.
Yeah, and so the thing I was going to say too, because this paper always blows my mind, there's a paper out there where they basically induced lens capsule rupture in rabbits as part of an experimental condition, and it didn't provoke the crazy inflammation you might expect. So kind of I would say that the overarching rule of it's thought that lens protein is basically sequestered from the immune system during development, and therefore any lens capsule destabilization, like leaking of lens protein or overt rupture, should provoke a crazy immune response. It doesn't necessarily always hold, I think. So that's what I mean, I think, when I say I don't think we completely understand like why, under what conditions the lens really provokes inflammation, because it is not as straightforward as I think it's historically been considered to be. Anyway, yeah, fun discussions. I mean, so I will also say that this whole debate, all these discussions and trying to distinguish between an early life acquired versus a congenital malformation type condition, it's all academic. It probably doesn't mean much to the animal. So at least it's one of those fun discussions where we can debate about it and like nothing like serious really hangs in the balance. So there's that. That's fun. But anyway, so this tortoise. So we have a 14-year-old intact male spider tortoise. This patient has a history of chronic keratitis for 12 years. Note that the patient is 14 years old, so this means that the patient has had corneal anomalies for at least since at least 2 years of age. So pretty much for most of this patient's life, abnormal cornea, abnormal eye. They can't see through the cornea to evaluate the intraocular structures, and they have a differential of congenital or early life acquired conditions. The patient recently became blepharospastic, which improved on meloxicam. The globe appeared slightly buphthalmic with possible periocular swelling, cornea lackluster with maybe a central area of mineralization, and limited blink or eyelid movement. So a pretty abnormal eye, but it's kind of been abnormal for a long time now. This picture is a little out of focus, maybe, or not out of focus, but basically it's a tiny eye and there's only so much resolution we can get. So you can see again with the scale bar here, very, very tiny eye. So we have the whole intact front view, and pretty much just like they said, clinically, this is a completely opaque cornea, pretty abnormal looking cornea. And then on the hemisected view, there really, again, isn't really much of a lens, at least grossly, visible inside this eye. It should be roughly here behind the iris, and it isn't. And then here's the cornea, just barely. It's a very thin cornea up here, but there it is. And there isn't really much of an anterior chamber. This iris tissue or pigmented uveal tissue is right up against that cornea. Once again, this should be a case that fits completely in one subgross view. Let's see, I think. In fact, more than, yes, two of them fit in one single subgross view. Actually, it was this way around this time. All right. Here we go.
Can you go 1x and get the whole thing?
Yeah, actually, we probably can go. You're right. We can probably go 1x and get the whole thing, which is always better than the subgross anyway. Wait, now it's the other way around. Yeah, we can. So, all right, let's just go 1x and get the whole thing. Or 20x or whatnot. It's a little over the edges. No, it isn't. Actually, it's in the whole field. Anyway, so here we are with this whole small globe. So once again, we can see on the histology. So we've got this scleral oscles here and here in this tortoise this time. And we have the scleral cartilage, just like our owl, here and here. And so we have our scleral oscles, one on either side, and we actually have formed iris leaflets in this case. So here's iris, here's iris. And so we do have a pupil right here. And so despite being at the level of the pupil, we should be through reliable cornea at this stage. We don't really have much of a normal cornea once again, which we'll see closer up to, and we don't have a formed anterior chamber once again. We have a artifactual retinal attachment. Trust me that's artifactual, and we don't really see much of a lens from low magnification, but we will go closer. So here's our cornea. The corneal epithelium is really hyperplastic, and it's also quite keratinized. So there's a layer of keratin on the surface of this, this bright eosinophilic stuff. The cornea is supposed to be transparent. It's supposed to let light through in all species. So keratinization is abnormal. It is one of those things that can make a cornea opaque, as it was seen clinically and grossly. And then also the corneal stroma is once again abnormal. It's pretty much a disorganized fibrous tissue, very heavily vascularized in this case, and kind of mildly inflamed. So we do have a chronic keratitis. Once again, there is no evidence of a Descemet's membrane at this level anywhere. We don't see it, it's gone. And the iris leaflets, or anterior uveal tissue at least, broadly blends into this abnormal cornea with complete collapse or absence of an anterior chamber. If we look adjacent to this defect, we have this wispy and kind of unhappy looking basement membrane. And this is actually lens capsule. But there are no normal lens fibers here to speak of. They're completely absent. So it's just a capsule, and this capsule kind of tracks towards and fuses into this abnormal cornea up front. And in fact, since we're here on high magnification, let's take a closer look. Heterophils, they're so pretty. Pink. And probably some lymphocytes as well. Little bit of keratitis. So a very similar presentation in this tortoise as compared to our owl. We do have another view of that lens capsule in a slightly different plane of section that I'll go ahead and show you, but other than that, there isn't much else to show you. This cornea is oriented in a little bit of a different fashion. This is not quite through the pupil, so we're a little bit off center here, and we have the lens capsule kind of at its edge. Again, lacking any normal lens fibers, and actually there's a couple of heterophils inside this lens capsule, so a little bit of a phakitis in this case. So once again, we have very similar findings in tortoise as we just looked at in a great horned owl. So all species, great and small, it can have similar debates between congenital and early life acquired anomalies. And indeed, these are our differentials for this case as well. However, in this case, I would be more in favor of an early life acquired trauma, or basically chronic sequela of trauma, because the patient was maybe at least 2 years old by the time corneal changes started, maybe, and because the uvea is relatively well formed in this case. So that said, once again, it's like the before. You could probably make a convincing case for congenital. So even though I would favor trauma in this case, could potentially be an anterior chamber cleavage syndrome as well. So similar deal, different species. And that's it. I have nothing else to say. I believe, let's see. Yes, it is. I will hand the floor over to Kelsey Brown, our lovely new Coplow pathologist.
Yes, that was very attractive to me. All right, hello. So I have two cases, perhaps not quite as intense as the ones that Dr. Kleiman's just showed. So my first one is going to be a glow from a dog. So this is a 6-year, 6-month-old male castrated mixed breed dog from Arizona. And history we were given is that this globe had severe scleral vessel injection and conjunctivitis. It was non-visual, had a mydriatic pupil, retinal detachment with ventral medial red-brown mass suspected in the posterior chamber. So here is the gross image from that globe. So presumably this is the mass that they were describing clinically. So it's more of a vague thickening in the sclera and episcleral tissue, potentially just kind of bulging to maybe also involving the choroid, but we can look more closely histologically. Otherwise, they did describe retinal detachment, which we can see here. Otherwise, the rest of the eye is somewhat unremarkable. Those are kind of the two main things we can see grossly. We can't quite see the optic nerve head due to the retinal detachment. So it's been a second since I've been at this scope. Yeah, remember how to do everything. Stand by. 11. All right. I've always been very bad at doing the subgross view. I'll do my best. Dun, 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 dun. All right. So we have our cornea on the left. The anterior segment of the eye is relatively boring, for lack of a better word. There really isn't too much to describe at this low power view. As we move posteriorly, though, where we had that described mass effect, there is pretty severe thickening of, as I mentioned, the sclera, the episcleral connective tissue, and then also the choroid. It's kind of hard to tell where the choroid starts and the sclera ends. And we can tell that there's just too much blue here. So there's a dense inflammatory infiltrate, and it's centered on all of these kind of linear and cross sections of, I guess I'll just spoil it when I get to be parasites. So I'll look a little more closely at that. And then again, here's our detached retina. Other things we can see at this view is that there is this kind of high protein fluid within the subretinal space. It also ends up being in the vitreous as well. Right. Without further ado, again, remember how this microscope works. Focus. Oh my gosh.
The big one.
I should have done the big one. I really. All right. So this eye has been flipped 180. So we now have our cornea on the right. I go up one. And as I mentioned, there really isn't too much described in the anterior segment. I can go to the main event and then we can kind of clean up with the other details. But I feel like this is what everyone probably wants to see. So here is our mass effect that was described, going more closely and avoiding the parasites, looking at the inflammatory cells. That's what we all see, right? So these end up being coalescing pyogranulomas. So here we have a lot of epithelioid macrophages. These are little neutrophils with the squiggly nuclei. Then kind of at the periphery, we have bands of fibrous connective tissue, lymphocytes, and plasma cells, kind of mixed inflammation. Let me see if I can find a good one to go and describe. My eyepiece. You know, let's do this one. It's probably not the best one, but okay. So these are nematode parasites. They have a eosinophilic cuticle, this outer layer, which perhaps this is not the best example. I can move around a little bit more, but they do have these pretty prominent cuticular spines. I think this is a little bit of a tangential section, so we can kind of see it there and there, but then they start to get a little blurry. So they have coelomyelium polymyarian musculature. So this is their muscle layer here. They have a pseudocoelom, so all this clear space, and then they enclose cross sections of the intestinal and reproductive tract. I'm gonna move around a little bit just to find a good example of what else is going on with their repro tract. Stand by. I want to find there we go. So this one right here, this is the reproductive tract, and it has a few little microfilaria within it. So this is a filarid nematode. All right, and I was hoping to find a little better example of the little cuticular spines, but that may be the best we have. So like here, there's a couple of them. Yeah, y'all are convinced. All right. And so given this location, this appearance, we have these adult filarid nematodes. This is most consistent with Onchocerca species, which is, as I mentioned, kind of the main event of this eye. And I guess what's a little fun is that all of this inflammation does extend into, here we go, the adjacent choroid. But it seems like the filarid nematodes are mostly confined to the sclera and episcleral connective tissues. So then just kind of quickly looking at the other parts of this eye, we do have pretty mild vascularization of the cornea. In some areas, a pretty delicate fibrovascular membrane that's lining the anterior surface of the eye, and a mild to moderate lymphoplasmacytic uveitis, most severe in the choroid next to our filarid nematodes. Our lens was unremarkable. And we have a true retinal detachment with outer retinal atrophy. And then just this kind of, bland eosinophilic homogeneous material within the subretinal space and vitreous. And they did describe glaucoma in this dog. However, we were not able to corroborate that because the optic nerve head is just distorted by the detached retina. And those are the major features of this eye. So I will go to our diagnoses, which I cleaned up a little bit because they were a very long list. So yes, due to the location, the morphology of these parasites, we diagnose this as Onchocerca species. In dogs, typically, it's going to be Onchocerca lupi. And this parasite has kind of a hyperlocal location that we find it in. So usually the Western US, including Arizona, which is where this dog was from. But there are also reports in California, Nevada, and Utah. In this particular case, actually, I'll go back, something that we did mention in our comment, F11, get it all together, is that there are areas where these parasites do approach the surgical margin. We didn't trim this tissue at all, so we did caution that maybe there are some residual parasites left over within the orbit, so just to monitor the surgical site. But otherwise, that is that case.
Right, and just to add another location for our national there in Europe, Greece is another place where, well, the original cases I think that we put together were from Greece, close to Thessaloniki. So I think there's it kind of requires a very specific geographic arrangement where it's a very these cases often come from a place where a very dry climate near like a water basin of some sort. So they are hyper localized and it's impressive. Like Salt Lake City, main thing, Arizona, and then Southern California and Greece. Are the places that be careful what you do there.
All the vacation locales.
Arizona golf courses.
The golf courses. All
Beautiful
right.
case.
Yeah, it's a lovely one. Okay. And move on to my next one, which is also a dog. This is a 9-year-old female spayed mixed breed dog from Florida, but that's less important. And the history we were given is that this dog has secondary glaucoma, a mildly ophthalmic eye, retinal detachment with white infiltrate / plaque, and hemorrhage with subretinal hemorrhage. And then they also diagnosed iritis / pre-irital fibrovascular membrane. So
just to add, Karen Aranjo here, she's in Spain. She said southern Spain too,
southern Spain. Wow.
Thank you.
Yeah.
aka northwestern Greece.
Ooh.
Joking, Carol.
They're both beautiful. All right, so here's the globe from that eye. And we do have a pretty discrete tan to white mass within the posterior segment, butting up right against what is the detached retina, as well as the optic nerve, and kind of broadly abutting the choroid here. Otherwise, the vitreous was kind of this cloudy gel. The anterior aspect of the eye was somewhat unremarkable from gross examination. So
Locations are popping up here. I'm sorry to keep.
Oh my
going.
gosh.
So Colorado too. Aaron said,
really, Colorado.
Riley Aronson said in Colorado she had a couple cases there. Gotta expand.
Gonna
into the-
put together a whole
Maybe not that
list here.
hyper localized. Forget about that. Mhm, yeah,
So kind of the same region though.
multifocal.
Okay, so here's our other eye that does not have Onchocerca. So we have our cornea on the left here, which, as similar to the other one, the anterior segment's pretty unremarkable for lens. And then as we go back, we do have a detached retina and a similar just kind of proteinaceous material within our subretinal space and vitreous. And then here is our mass. So as I described, we have this mass effect. It's kind of infiltrating our optic nerve head, and it is just broadly abutting our choroid here. We will go a little more. Let's check it out. And focus. Let's back up one. Okay, so we have our cornea on the right here now. So going to the posterior aspect to look at this mass. You can see from low power that it's unencapsulated. I'll go to areas where it starts to infiltrate the optic nerve head. We can see that it's infiltrative and poorly demarcated, and it is densely cellular. One more in even. And it is made up of these spindle-shaped cells that are making a lot of pretty wacky patterns. There are some areas where they kind of do these like store-form patterns, which is somewhat akin to like a child's windmill or, yeah, it's a windmill, right? What they blow, it spins. Yeah. Pinwheel. There we go. Not windmill. Windmill's a little bigger, but maybe a similar idea. And then they're also just doing these kind of short, haphazard and intersecting streams. And these cells have indistinct borders, a medium amount of amphiphilic cytoplasm that's a little bit wispy in areas, an oval to round nucleus, this kind of coarse to finely stippled chromatin, and then one prominent nucleolus. There are mitoses in here. We got 6 mitotic figures per 10 high-powered fields, so it is performing a little bit of mitotic activity. I'm going to go kind of across over here where we get our other section of mass to show some other features. So there is pretty significant areas of necrosis along which these cells will sometimes palisade along. I'm going to see if I can find a better example of that. Maybe this one right on the fold, where we do have cells that kind of line up against those areas of necrosis. And then within this section too, we have these little kind of pseudocystic or microcystic areas. So we have this eosinophilic material that these cells are kind of surrounding. And it's pretty large regions like that, like right here. And other features, these cells do exhibit a little bit of pleomorphism. So there's in areas mild anisocytosis, mild anisokaryosis. There's the occasional karyomegalic nucleus, which of course I'm not able to find in field. I'll keep moving around, see if I can find it. So given this location and the appearance of these cells, we said this was most consistent with a optic nerve head or retinal glioma. Yeah, I'm not going to find that. Carrying megalic nucleus. Don't listen to me. And it is infiltrating our optic nerve head. But if we go posteriorly, we don't see those neoplastic cells. So this is a clean margin at the optic nerve head. All right. So then just looking at the rest of this eye, if I can focus it, there we go. There is, similar to the other case, just mild vascularization of our cornea. This eye does have a pretty thick pre-irital fibrovascular membrane right here, which is also showing us pretty active hemorrhage into the anterior chamber. Sure were. There's a mild lymphoplasmacytic uveitis. And also worth pointing out, there isn't any pigmentation along the anterior face of this iris. So this is a blue eye. Not necessarily significant to the diagnosis in this case, but fun to see. And then, as I mentioned, we do have a detached retina, which is pretty much kaput at this point. It is severely atrophied. And then just some hemorrhage, that proteinaceous material within the subretinal space. And this is a panuveitis. We also have some inflammation within our choroid as well. But otherwise, those are the fine features of this eye. So I will go to our diagnoses, which I've heavily cleaned up to say optic nerve head / retinal glioma. And these were clean margins, which is great. So for these optic nerve head retinal gliomas, in the central nervous system, gliomas will typically subclassify into astrocytoma or oligodendroglioma if able. They're also assigned a grade. Within the eye, that is not typically performed. For grading especially, it's unclear if that has any prognostic relevance in the eye. It would seem that the majority of them are high grade technically, but most of the ones in the eye have good prognosis if we remove them with clean margins, as in this case. So it seems like that grading scheme doesn't really apply to the eye itself.
Yeah, the most important prognostic feature would be extension between the optic nerve margins for possible recurrence or extension to the brain. And you're right, if you use the WHO classification or the classification for glial tumors in the brain, most of them will qualified as mixed gliomas and high grade, which doesn't necessarily correlate with the prognosis that we would expect in the central nervous system versus, well, in the brain and spinal cord versus the retina and optic nerve.
How often do you see bilateral involvement?
Not very often. We've seen cases where there were dirty margins where the tumor extended up into the optic nerve all the way up to the chiasm and in the visual cortex of the brain, but I can't remember the bilateral case. Bet that if we look for it, we might find some, but cool.
Cool.
Well done.
All right, and I will pass the mic to Dr. Jamie Miller. Next slide.
Awesome. All right. So next up, we have the right eye from a 9-month-old golden retriever poodle mix from Texas. Not super important. So the history that came with this eye was back in August. The right eye was ophthalmic and had diffuse corneal edema. And I guess when they were seen, it had a well-incorporated conjunctival graft that had, let's see, sorry, they put the history in backwards order. So the dog underwent a primary corneal laceration repair and advancement conjunctival graft in March of this year, and then subsequently developed secondary glaucoma. So they, ophthalmologists saw a ophthalmic eye with a corneal edema, again, a well-incorporated conj graft, a collapsed anterior chamber, and they could not appreciate inside the eye. They said yes to glaucoma. So This was the hemisected view of our globe. We've got cornea at the top here. Indeed, the anterior chamber is quite collapsed. It's not there because we've got uveal pigmented tissue all around or all along the posterior aspect of the cornea. I don't think we can see it in this view because I think it ended up in the other half of the globe, but the conjunctival graph still looked pretty good to us. And then what we do notice is that there's this pigmented tissue extending from the uvea and connects right to the lens. That's also quite flattened and a little bit misshapen there. So we have this like stock of uveal tissue connected there. The other major thing here is our retina is partially detached and it has lots of multifocal holes in it, which was quite fascinating to see grossly. So let's take a look at this globe a little bit closer. We had to do a couple sections to actually get a good look at our features here. Go. All right, so finally found a nice connection here in this section. So again, cornea at the top. Here's our pigmented uveal tissue along the posterior aspect of the cornea, and then that stock of tissue that comes down to our lens. And then we sampled quite nicely our retinal detachment and a couple different holes in it. The other side of the retina is also not quite normal either, and we'll take a closer look at that. And here's our optic nerve at the back. All right, so if we start up at the front here, there's quite a few things going on in the eye, so we're kind of take it step by step here. The first thing that sticks out here in the cornea, our epithelium is a little bit hyperplastic, and we can see this chunky, deeply basophilic material here, either in the basement membrane or anterior corneal stroma. And this is some mineralization. So we have some band keratopathy, got some chunky stuff here in the anterior stroma and a little bit, kind of maybe a little bit more fine granular stuff in the basement membrane there. If we look at this location here, we can see basement membrane coming down here, and we can maybe see the mineralization highlighting here. The epithelium kind of bunches out or is lifted up a little bit, and you get a little bit of more fibroplasia underneath it. And so this is anterior stromal remodeling, which is indicative of like a previous detachment or bulla from here, potentially ulceration that has kind of remodeled and is trying to repair itself. All right. Yes. Okay. And so then here is our stock here of tissue. It definitely looks like uveal tissue. And if we get a little bit closer here, we can see Descemet's membrane as it comes along, and then it stops about here. And so this is kind of over a break in Descemet's membrane. There's a little bit of fibroplasia in this deep corneal stroma here. So there was a previous break here. Sure, it picks up on the other side. And then we start to see it come back in on the other side. And as we keep going towards the periphery, we can appreciate another little break. So here's Descemet's here, and it kind of bluntly ends here, a little bit of fibroplasia. And then we pick it up again over on this side. So a couple breaks in Descemet's membrane. And then if we go back, we can see that our iris tissue here kind of blends with our anterior lens capsule. Is connected here with some fibrovascular tissue that connects and surrounds kind of the lens. The lens has also got a pretty hypermature cataract. We've got lens capsule wrinkling, and we've got degeneration of the lens fibers circumferentially around it as well. And then again, our retinal detachment and tear. So we've got some nice rounded margins to these discontinuities in the retina, which are indicative of a true in vivo tear in the retina. Sometimes it can be artificially torn due to processing, and that's usually a more boxy looking appearance to the ends. So that rounded margins helps differentiate those things. And then on this side, as we look at the retina, we can see, ooh, fascinating. Okay, right there. That there is some clear space here in between the inner and outer nuclear layers of the retina. And so this is edema or retinoschisis, which is just a long-term finding in retinal detachment cases. So this retina's been detached for a little while. The optic nerve head was a little bit distorted from the retinal detachment and such. So, and that's what we have in this one. If we look at going back to the cornea, again, as I mentioned, we didn't quite capture the contrast in this section, but we do have this little epithelial inclusion kind of right here in the limbus, which is probably a secondary sequela of the surgery of them moving the conjunctiva forward there. So we took a radial section in the area of the contrast. So here's our cornea. Here we've got some distorted anterior uvea here. And then we head back again, that would be towards the posterior segment. So if we take a closer look, the corneal stroma is a little bit more densely collagenous here. There's no real good distinction between what was maybe once conjunctiva and cornea in this area. So a nice incorporated conjunctival graft. And then as we keep going posterior in the limbus here, we can appreciate a little bit more dense fibrosis here. And then if we keep going, we start to see other stuff here. So I'm going to go to this one. So this one looks like more an island of epithelium that's kind of back here. Again, could be from the surgery, but it's starting to get a little bit posterior in the globe here. There's a little bit of necrotic debris. And then if we go back to this one, we can see that these cells around this structure in the center here are not epithelial cells, but macrophages. And then we can see this structure with walls here. And so we've got some plant material here in the limbus and the sclera that's surrounded by a little macrophage response here. And I promise I will polarize it in just a minute. And so we started to look, and if we kept following, we can see more of the fibrosis as we start heading back towards kind of the equator. And we start to see more. This one looks a little bit different. It's definitely a little bit more round. Has a little bit different kind of internal structure to it. And if we keep looking, we will also have got it inside in the iris and ciliary body. Again, these guys looking a little bit different from each other. This one's got kind of like a cortex with central plant type material. And let's see, this one looks a little bit more like that was out there in the sclera, a little bit more boxy. And so, see if I can get this to polarize for you guys. See if we can do this. Whoa, let's see. It's bright. It's not gonna work. Here we go. Oh my goodness. Oh no, it's not gonna work. Here we go. Here we go. Let me see if I think the camera is going to correct too much for this. Let's see.
There it is.
We can sort of, if I don't do it, whoa, to the extreme here. Let's get it in focus for you. It's good. There we go. Maybe if I do it a little bit slower. Yeah, you can start to see the refractal nature of the material in there. And we can see starts to light up this piece. We've got these pieces here. And then I think there's good. And then, yeah, there's just a few more pieces inside the iris stroma as well. So that was an interesting find, not what we were expecting to find here. And then just one more view here in this radial section. I put it upside down. So again, here's cornea. We've got still more material here. And again, epithelial inclusions kind of way back towards the equator, more fibrosis. And then if we look inside the eye, again, we've got this thick basement membrane here. That's probably lens capsule. So there was probably lens capsule rupture in this case as well. Again, very minimal inflammation. Only saw it around that one piece in the sclera there. No real good inflammation inside the eye. But it's just kind of a fun finding. Not really what we were expecting, but it was cool. So we have a postoperative corneal laceration repair with advancement conjunctival graft. There was lots of kind of fibrosis in the limbal area and the iridocorneal cornea angle, and a lot of intrascleral and intrauveal like plant inorganic material with very minimal inflammation consistent with previous trauma or laceration. And that's possibly what instigated the original corneal laceration back in March, potentially. We've got that interesting synechia of the anterior uvea kind of along the posterior cornea into the lens itself as well. A hypermature cataract, lens capsule rupture, and then our diffuse retinal detachment and multifocal tears in retinoschisis, which that also could have been potentially from a penetrating trauma, those retinal detachments and tears. There's also some vitreal degeneration, I think grossly, and some of that retinal detachment could have been from that as well. So just a interesting case with some surprise foreign bodies and no evidence of neoplasia. So that's good.
We only got 2 minutes, so probably gonna leave it there.
Yeah. So,
Thanks everyone for joining us.
yep, great case discussions today. We'll see you guys in 2 weeks.
Thank you.
Have a great day.
Bye-bye.
Right.